Afternoon, colleagues. Welcome to Report Out. So I've worked for 8-9 years in improvement, and today I'm on debut to host Report Out. I'm afraid we've had apologies from all of our executive team for various reasons. For the first time ever, despite Rowan's best attempts at recruitment, he's ended up with me. So it's great to be able to do it. We've got a couple of things to share today. Linda, as you just heard, is going to give us a 60-day update on their RPIW work around improving prescriptions for home care, which is great. There's some massive improvement done in the early days, and they've sustained it at 30. So excited to see if that's been maintained as well, because sometimes just maintaining stuff is a really significant achievement in the current context. And then I've got a sense that the work we're going to hear from Kirsty, Lee and Kate, Monica today has been a long time in the making, because I've seen hints of it, I'm sure, quite a long time ago. So I'm really pleased to see that come to Report Out as well. And so without going on any further, I'm going to pass to Linda over to you to tell us about the progress with your workshop. Thanks.
Thank you. Can I just check you can hear me okay? I've not yet. Lovely.
We can. Thank you.
Thank you. So, afternoon, everyone. My name's Linda Bailey, lead nurse for rheumatology, and I am a process owner alongside Helen Lynch from pharmacy for the Homecare Imp-Rheum-Ving home care for LTHT. Next slide, please. The Leeds Teaching Hospital's medicines expenditure for 2023 was approximately 300 million, with over half of this attributed to home care medicines. The home care services has grown significantly over the past few years, expanding by 50% since 2019 alone. Rheumatology represents the largest cohort of patients within this service, currently managing around 3,500 patients going through home care for subcut biological therapies. Before the initial rapid progress improvement workshop, the process was observed to be conducted in silos, with limited collaboration between all teams in a flow. This led to batching, bottlenecking, delays in prescriptions being validated, and generally a low morale within the team. Managing the workload for 3,500 patients is a substantial amount of work, and it's a really big task, especially given the limited staffing resources available to meet the demand. The goal was for the multidisciplinary team to fully understand the challenges and pressures of the services and come together during an intensive improvement week to transform the services for the better, demonstrating true teamwork and a shared commitment to patient care. So in the recent improvement project, we identified that the overall lead time for a single prescription move through to complete the process has been significantly reduced from 24 days to 8 minutes. That in itself is a remarkable achievement and proves, that the process does work. We was taught within the week, trust the process, and it's true to its word, it can work. However, as we all know with improvements, the challenges lies in embedding these changes effectively. After the initial 30-day period, we remeasured the lead time. And while it hasn't maintained the 9-minute mark, it's stabilised at 8 days. This is still a significant improvement and testament to the progress made. At the 60-day period, unfortunately, as you can see, the overall lead time has risen almost to pre-RPIW week. Reviewing the reasons for this would suggest staffing shortages as the main issue, and I'm assured that is the reason. The work in progress initially identified at 750 hours has, however, continued to see a decrease from 662 at 30 days and now down to 506, and that's marking a 33% decrease. This reduction is commendable, especially considering the challenges that we've faced over this last month, with the staffing shortages. The home care hub itself at Chapel Allen has been instrumental in reducing this. Additionally, as part of the Rapid Progress Improvement Workshop, we engaged with patients to gather feedback on transitioning to an electronic communication method for blood test reminders. That was one of our biggest defects. The pre-process was reliant on paper and using external postage, and was really lengthy in time, with up to 2 weeks for the patients to actually receive the letters, and it was outdated. So the feedback received from patients have been overwhelmingly positive. We're putting in a text messaging service in place. This was delayed slightly due to accessing the system and also staff training, but now staff have started to use this service over the last week, and already within 1 week it's been used successfully with 112 patients. So just in 1 week it saved all the the letters going out and the time of staff sending out all those letters. So the newspaper report. So the problems that we've had is the hub. So we have moved into the hub, but it's become apparent that it's not conducive. There's too many staff in there now, and also it's a shared space at the moment within the outpatient setting. So we have looked at expanding that hub, and we've been greatly supported by Chapel Allerton Tri-Team in that expansion, and using a further shared space within the outpatients department. The problem has been like the workforce depletion, when we've had unplanned absences alongside staff annual leave. And again, I think we need to explore those opportunities that, although we are all collectively in the hub, we do seem to be working in silos within the hub. So it's looking at different skill sets, within the teams of, how we can cover each other if we have these unplanned absences. And the tracker, unfortunately, that's on there as an error that has been resolved. So key learning, what have we learned over the last 30 days? So although physically, as I've mentioned, most staff are now working within the hub environment, interruption of the depletion of the workforce, has had a massive impact on that the lead time. Improving communication within the CSU to not just within who it involves with the team members moving. It's about sharing that information, different working environments within the whole department, and hopefully that will help that engagement of staff and the importance of shared spaces and having those agreements within those areas, to be respectful to each other. And also key learning, it's the commitment from staff, who ultimately avoid all these delays happening, which, ultimately what we want to provide is that positive patient experience. So next steps over the next 30 days, expansion of the hub. We hope that that's in place within, at our 90-day report out. Again, further discussions about how we can support each other within the team when we have the unplanned absences, and improving that communication across the CSU of different working environments. Thank you.
Thanks very much. Appreciate the honesty that you've brought to that. It's not always plain sailing, and obviously for our patients, we'd want to see those huge improvements that you managed in the week to sustain. But it sounds like the team is still remaining committed to the work and exploring the opportunities there. So we'll move on, but questions to follow. So thanks ever so much for a really clear report out. I'm going to pass across to the children's paediatric gastro team who are sharing next. Thanks very much.
Afternoon, everyone. My name's Kirsty, and I'm a member of the Children's Hospital Management team, and I'll just let everybody else introduce themselves.
My name is Lilian Gomez. I'm one of the gastro consultants in LGI.
Hi, I'm Kate Haig. I'm one of the business managers in the Children's Hospital.
So we're here to talk to you about our project, our work as a project together within the paediatric gastroenterology team. So together, this is our improvement goal that I'll just describe this to you. So to ensure referrals for our common paediatric gastroenterology pathways are directed to the appropriate department the first time that they come through to us. What we expect and hope for in our work on this is to reduce triage time and overall demand, creating a more efficient pathway for patients whilst optimising the use of our collective time and resources. So Lilian will just explain the challenge and background.
One of the first things we had done is to do a snapshot audit of 5 weeks. That is one of the LIM tools. Normally we do our referrals when we are on call, that means 1 week, but I take over 5 weeks with the idea of having a better image, better idea what was the problem. And it's because our waiting list for follow-up patients and also for new patients is big. During these 5 weeks, I was able to accept 30% of the patients. That means 1/3 of the patient. That is around 4 to 5 patients a week. That is a number that we can see without any problem. One of the collateral success with the snapshot is that I was already reducing the list. I present the results in a brainstorm meeting with my colleagues and also with managers. And one of the clear things that we see after this audit is that there is no joint protocols or no referral pathways guidance for GPs or any referees.
So I think when we came together, Liliane had made obviously a fantastic start, and this has been presented out to the team, to the consultant team and management. So we came together as an improvement team and started the LIM course together, and I think we could kind of sense each other's commitment, which was a really great start for this. And we used kind of just a project brief between us just to really clarify the objectives and kind of our first steps, next steps as a team. And then from there, we were thinking further on the engagement, how important it is to involve, not only to involve them, the people within the process by engaging them, but also to gather their view in terms of that challenge from their perspective. So we did a couple of things. So we sent out, we used forms to gather people's views. So on the right-hand side, you'll see that this went out to the whole of the gastro team. And I think these couple of comments are a really nice summary. So I think providing clear guidelines regarding when to refer and tests expected required beforehand would be helpful. And I feel that there's no consistency with how referrals are triaged. The left-hand side is what went out to a couple of our GP leads. So we hoped we could engage them and work with them on this. But Liliane had already put the celiac guideline together. So we used that to send out to almost gather views on that, giving them something specific to start to feedback on. And it was really, really useful to help us to listen to them as well and see what their thoughts were before we came together. So the first, I'll just read a couple of things out from here. So how is this going to be made easily accessible, easy to follow and easy to do? That's the most important, I think, general comment from GPs, which we need to understand. A couple of the things they said are allow an ICE to book the correct test. So would it need to be clear on ICE as to which test was needed and when? I'd much prefer to submit a referral after initial test in the paediatric department, then complete any further testing biopsy. So the question around who was providing that second test, the questions around use of a DART form, which we've used within children's, and I know we use them elsewhere, but does this need, is this something that we could look at more of a structured referral form for? So this was a really great start with engagement, and then from there we were able to form a working group with our GP leads because we had a good response. So this is the process mapping for the first. Sorry, Kate. The first. This is the first. Celiac was the first pathway guidance that had been put together.
So as part of obviously attending the LIM workshop, we looked at the tools that was available to us, and we decided to do a process map to see where the wastes were within the process and the current process that we have. As you can see on here, we could quickly identify where those wastes were, what the time was affected, how it was affected in terms of clinical time, admin time, and also time for the patient waiting. And a patient was approximately around the 25 to 30 weeks before they were even getting to a triage or a decision as to whether we should be writing back to a GP or whether we should be accepting that patient. So from that, it was really easy. Rather than using a spaghetti diagram, we decided to use the this flow chart so we can see what's coming in, what actions we need to take, and what we need to take back to the team for further communication.
So we've put together with help of the KPO team as well, what this highlights, and when we start to look at some of the metrics and thinking about, the need for guidance, the need for understanding the numbers in on a weekly basis, how many were rejected, and those kind of questions that on a regular basis, and almost our access and performance information, we have so many reports that we gather that from, but how can we make this easier as a wider team for an improvement perspective, but also through regular meetings to look at our metrics. So we thought we'll have a production board, really easy accessible on Teams, Microsoft Planner, that everybody can click some key common reports that are useful, and you can see that kind of in the second column, and then in the third column that snippets of the improvement work, which projects are underway in response to some of that metric. So this board, through introducing it into business teams, is really, really useful. And we've also generated a new report in terms of talking to Liliane and what would be useful. And I'll hand over to Kate for the next slide for that.
So as part of improving our data and being able to track any changes, we had this really helpful report produced so we can clearly see the flow in and out for the teams of the referral, registered and the numbers rejected. It was also very useful snapshots of data that clinicians can easily access and interpret for new improvements going forward or any further projects, and where we can look on different pathways that are referring in. And we're slowly building this for further data for our inpatients as well as our outpatients.
After doing the snapshot, what was clear is that it was some pathologies or symptoms that it was repeatedly presented, and I was able to identify the six most frequent ones. That some of them, actually, there are pathways that we share with other specialties, for example, abdominal pain with the pediatricians and PR bleeding or gastroesophageal reflux with the surgeons. That means that in some occasions there is double referral, and there is two teams working with the same patient for the same thing, and sometimes we have the different approaches. That means that it was also, we detect there that it was another waste. The idea was to start with celiac disease, the first protocol, the first pathway. And our next plan also is to do diffusion to explain in different forums the pathways. We had not started with this because we just had approved the first pathway, that is celiac disease. Actually, I choose celiac disease because there is a clear pathway guidelines from the European Society that also is endorsed by the British Society. We receive more or less 4 to 5 new celiac patients every week, new referrals. And when I time myself for doing the referrals, because I have to call the patient, sometimes I have to repeat bloods or request scopes, is around 25 minutes. I mean, it's a long time that we spend for each patient. And this pathway is really simple. It's only 2.5 pages. If you can go through the pages, please. In there is like a general information. Also, there is like the questions that most of the specialists or GPs ask us, and there is different answers to these questions. And the last one, can you go to the next one, please? And to the next one, the last one is a summary, easy summary for patients that came from Leeds and patients that there are no from Leeds.
So this is kind of the new landing page within Children's for referral guidance that the ICB and GP Leeds have kind of asked and helped to develop with us. And I think one thing that came through that the GPs described was the amount of places they can go to access referral guidance. And this is kind of our attempt at trying to bring it into one space and make sure that this is fully up to date, but also trying to update other areas too, because it's important that we don't allow things to fall out of date that whilst we're still using more than one area. So this, we've kind of said that it would be great if gastro was almost a gold standard, and then working with them on making sure we've got, you know, really clear pathways, any patient information, anything that needs to go in here to help. So we'll do that alongside them. So in terms of what went well, and from here, so when I mentioned the team approach, I think we said how committed we all are as a team, and I think it's worked really well with this being clinically led, but then having strong kind of, you know, business support around it, because there's a number of us, and it helps in terms of the project management, in terms of the relationships that we've got. And the next step, and we actually have a meeting planned in with immunology and automation and the GP leads and gastro. So when we're talking about improvements around, you know, efficient pathways, it's massively important that we have that partnership working. So I think from this, that's one of the really what went well for us, and the response that we've had from the GP leads, and just a couple of those tools, and even just sending out some simple questions around that first pathway with people who we thought would respond. I think it's really helped that everybody's listening to each other. So it's again really good partnership working. And Lilianne's also able to bring in 2 students, so 2 year 4 students who are going to come in and help, which will also then look at kind of audit against those guidelines and do some time in and write further guidance too. So that's massively helpful, to strengthen the team and keep us going, keep us moving on. So the next steps from here, again, to keep that working group going and keep pushing through as a team. And the plan is then to almost use this approach, talking about that page on Leeds Health Pathways, where we're really working hard, and our guidance to do that across all specialities within the Children's Hospital, to do those checks and see what's missing, because we know that when that's missing, it causes massive problems for us and patients coming through, and waste of time and resources. Thank you.
Wow. Thanks very much. I can see why that has been in the pipeline for quite a while, given the breadth of the work you've done. I've made a few notes because it's the only way I can hang on to all that information. But I'm keen to see if colleagues on the call have questions or interest before I chip in. So just look to people who've joined. If they've got any questions, pop it in the chat if you prefer, or come on mic, pop your hand up. Loads of stuff to go out there. Who's got a query? Afternoon, Tony.
Just it's a question regarding the pharmacy report out. Obviously, Linda, we know that the touch time for this process is 8 minutes. But what you've identified, it seems to me, is that 8 minutes is completely dependent upon the skill sets, actually, of all the various contributors being present, and that if those fall down due to absence either planned or unplanned, then the eight minutes retreats back to the pre-RPIW level. My question is this: had the new way of working not been in place, would the deterioration have been even greater?
Good question. I don't think it'd have been greater. It would have still had the same impact. I don't think it'd have been greater. No. It'd still cause the problems and still cause, the increase of the lead time, certainly. But I don't think it'd have been a greater impact.
Right.
And that's
so
what we've... That is certainly what we've learned from this, that, once one part of the, the production line, so to call it, goes down, then it all stops, and it's causing, that bottleneck again. And that's where, there's the saying, isn't there, of expect the unexpected. Well, that's certainly, what's come out of, monitoring and measuring over the last 60 days. So that's certainly something that we need to, learn moving forward, about looking at those skill sets within the teams.
Yeah. It's a question of ensuring that you've got all the skill sets available to you, isn't it? Thank you.
Thank you, Tony.
Thanks for the question, Tony, in response, Linda. That's really helpful. And on a similar line, I guess one of our challenges to what can be anticipated, and therefore can a mitigation be in place to create that flexibility that we kind of would acknowledge is required. The challenge of doing that when you do have distinctive skill sets that guidelines say this is what we're allowed to do, and also perhaps challenging some of that historic stuff about, well, okay, well, where is a safe flex to make sure that we're providing the best care we can in a reasonable time frame for our patients. So yeah, appreciate that. Any other queries?
Well, Jimmy, just to say, apologies for joining slightly late. So I just sat quietly in the background, which is great. Just to say, so Linda, I heard most of your presentation, which I think is just amazing, and the dial that you've turned on the kind of numbers just is a real testament to the project. But I think also, as you came last time to tell us about the kind of people engagement in this, I think it's really great. And then for Kirsty, Lillian, Kate, Monica, I think again really great to see a very, very patient-centered, thoughtful piece of work that's actually engages the team in doing the right thing for our patients. And that's actually, you know, what we are all here for. But sometimes it's always refreshing and heartening to see a team working really collaboratively with a really patient-centered improvement approach to say, what do we actually want good to look like here? Particularly in the current pressures, I think, for both teams and both presentations about demand backlog, the negative press that the NHS is getting. So it's really, really heartening from both of you to hear, you know, that what we're about here is care and compassion and doing the right thing for patients and getting our teams to work with us to do that. So there's just a big well done to both teams. And I know you're representing a wider group of people who've done this work as well, which is always lovely. But just a big well done to everyone. Thanks, Jimmy.
Thanks, Phil. I'll pass to Jenny.
Jimmy, mine's the same to Phil's, and because it wasn't a question, I wasn't. So I'm really sorry I missed the first one. But just that point at which just our improvement work has the unique bit about being able to remain with the patient at the heart of everything that we do at the time when everything around us is getting more and more and more pressured, isn't it? And that, I think, is just such a vital strength in our Leeds improvement method at the minute. One of the reasons I was late is I was just come off a session with the King's Fund, and I was listening to my peer colleagues in other organisations just talk for an hour and a half about the money. And I don't think we mentioned the patient once, and we mentioned staff a few times. And I'm wondering whether it made me think, particularly then to come into the last 10, 15 minutes of report out, I'm not sure we're really realising the benefits and the strengths of our Leeds improvement method, which is helping us to keep the patient as our true north, because what I've just listened to has left me feeling like a number of organisations have lost complete and utter sight of that. So I thought it was brilliant, really good.
Thanks, Jenny. Linda, do you want to just make a comment back before we wrap up?
Yeah, I do. Yeah. Thank you both for the acknowledgements, firstly. But also, I think it's really important to, we emphasise the patient-centred care. And yes, ultimately, that's what we are here for. However, what this has taught me, I've been a leader for quite a while now, but what this has taught me, in this particular project is that also, it really needs to be staff recognition as well of how much impact that can actually have on staff, when we're moving, making changes and actually moving staff around that we may think it's, it's for the better, it's for the patient, but we've got to really, and it's taught me, I'm sharing the experience that, I've had to step back and think, do you know what, I need to, step off the pedal a little bit with the patient, also we've got the staff, to care for as well, in any change that we make. Sorry, very brief, but I just felt it's important to make that comment.
Thanks, Linda. Yeah, it's resonated with many. I'm sure certainly the people on camera I can see. I just wanted to say, indulge a couple of comments just with regard to the work of the children's team. I think if we look for an evidence, as Jenny's alluding to, of our method being so valuable, that is a fantastic example. It's collaboration between clinical and non-clinical teams, I really, it's not often we hear people crossing system boundaries with this, but essentially what you've identified is the GPs are critical and almost they're the customer, aren't they? Saying, we'd like some services from you. So you've gone out and said, well, what do you need this to look like? And built it from there with the patient at the heart of that, because the better we work together with colleagues across the system, the better the pathway is going to be for everybody and our patients being at the heart of it. So I just really wanted to call out there. You've taken the time, invested the time to understand the perspectives of the people involved and your stakeholders there, and then created visibility. They said, like, help us make it easy for us to get it right first time, make it visible, and you've invested effort, skill in doing that as well. So that really comes through. And then the next steps as a final point, how do we sustain and expand and do more with this? And how can we use technology to help us? Because that's important to do, to make it amplify the benefit, I guess, across not just the one pathway you started with, but the ambition for this to be easy for any kind of referral in, and that's better for every child who might need the service you're providing. So many great things. Thanks very much. Apologies for the 2-minute overrun. Really enjoyed hearing from you today. We'll see you next time. Thanks a lot.
Thank you.
Thank you.